So our first speaker of the day is Dr. Shum, Dr. Merrill Shum. Over 20 years of experience in hematology, oncology, internal medicine. And the reason why I wanted him to come and speak is because every time I was at PIH for part of my care, every time I would say something like, "Oh, I'm seeing my oncologist," they would say, "Oh, is it Dr. Shum?" And I would say, "No," and they go, "Oh, it's too bad." So I'm like, I gotta hear this guy talk and about like why he's such a great. No, he's a great doctor, and I'm looking forward to hearing from him what he has to say. So, Dr. Shum, if you'd like to come up and speak, if we can give him a warm welcome.
Good morning, everybody. Thanks for having me. Sabrina, thank you so much. And Calvary Chapel Ministry, I really appreciate this. I thought I was going to prepare a kind of a medical lecture, but I thought I'd keep it more kind of personal and talk to you guys about the typical approach that we deal with on a day-to-day basis. And then hopefully midway through the conversation, we'll start talking a little bit about survivorship. I have, I think, 30 or 40 minutes to do this. That survivorship lecture series is actually a 5-day course, so I apologize. It feels like I'm kind of running through a lot of this, but hopefully in the next section, if we can do a little bit of Q&A, I think I find that the most engaging when one person has a question. It seems like everyone else has very similar questions, and it's really interactive, and I can't wait to get to that next section. But just to start off, as you know, being told you got cancer is a life-altering diagnosis, and it really changes everything. It not only affects the individual, but also affects the family. Now, typically, when we are asked to come to the hospital to do a consultation, I try to tell the hospitalists or the ER doctors, please put a pause. Let's make sure we have the diagnosis definitively before we engage in the conversation. And the most important thing is really just asking the patients what he or she already knows, or what they know about why they're there, what tests have been done, or why they're being done. Once we have the diagnosis and we're ready to disseminate that information, we really try to make sure that we have family there, our nurses there, our social workers there, even having pastoral care there as well, because breaking that news is obviously a very sensitive topic. I get asked all the time by family members, can I just tell my mom or my dad about the diagnosis? I'll be a little bit gentle, and I really prefer that they do not engage in that conversation. And the reason is this: telling someone they have cancer is not the scariest thing. It's not having a plan after you tell the diagnosis. And so I try to discourage even some of our doctor colleagues who are not in the profession to try to not say too much, because typically they'll come in a room and kind of say, hey, we just diagnosed you with cancer, and they walk out of the room and good luck. Well, that's probably even scarier than hearing the diagnosis, because the most important thing is what's the plan? What are my chances? What's my stage? And that really is something that takes accumulation of data before you can come to that point. But when we break that information, we like to have everybody at the bedside. I know you guys who have gone through this or have supported family members, sometimes the information comes through one ear, goes through the outside, and once you hear, I got cancer, everything shuts down. And so oftentimes, we will then invite the families and the patients to our office and have a really strong sit down. I've always encouraged my patients to bring a notebook. There's going to be questions that are already written down that you guys may have for us, but also when we engage in our conversations, you're going to write down some of the answers to maybe some of the things I'm explaining. And so please have a notebook so you can always write down some tips. And our job, again, is not to tell our patients what to do. Our job is to really present options. So, Doc, what are my options? And collectively, together with family members and friends and the physician and the medical team, we come up with a plan. As you guys have probably seen in the commercials, there's tons of new treatments besides just the typical chemotherapy, which is strong intravenous medications. There's now targeted treatments. You'll hear these words, these buzzwords, precision medicine or next generation sequencing. When I trained in fellowships, we didn't have all these fancy genetic tests, and now we have all these fancy tests and really can kind of hone in on a specific mechanism for the cancer. And so imagine if we can just take a drug off the shelf and target a certain mechanism and just turn it off. Well, that's a little bit more, in my mind, that makes a lot more sense than just to give a blanketed chemotherapy, which is a generic drug that really attacks all the good stuff and the bad stuff. So if we can find something that targets that mechanism, turns it off like a light switch, we have all those options now. We will prefer to go down that route. And then the last thing is the immunotherapies. The immunotherapies really have come about in the last 10 years or so, boosting our internal mechanism, our internal immune system to attack the cancer, almost like it's attacking an infection. And we've made great strides. I think there's now maybe 46 indications just from the immunotherapy, either alone or in combination. So although that we have all these treatments, sometimes just throwing on a drug isn't the right thing to do too. We talk about physical health, but emotional health. And thank you today for talking about spiritual health. That's very, very important. We do have a lot of patients that understand they've gone through some of the experiences of other family members being treated. And even though we're throwing all these ideas of this drug, radiation surgery, some patients say, wait, put a pause on this, doc. I'm not sure I really want to do this. What if I just do nothing and just do best supportive care? Quality of life is the most important thing. I think a lot of us think about longevity, but it's really quality of life. Because I do unfortunately have a lot of patients that are in the hospital and are living longer, but they're feeling sick. So is that the quality of life that you imagine? So when making a decision to go for treatments, I think that should be the most paramount focus is what's my quality of life going to look like? And then if you made that decision that, hey, I think I want to try and do this, and we make that decision as a group, as a family, then we proceed forward. We try to take multiple factors, such as comorbidities, again, what kind of support, emotionally, transportation-wise, that the patients have, and age sometimes. I used to kind of restrict age. I remember I had this one patient, she was 100 years old. She walked into my office, and she said, before you even say, I know what you're going to say, Dr. Shum, before you even say you're not going to help me, I just want to let you know, in my mind, I want to do this. So figure it out. And I'm just shaking my head. I'm like, 100 years old, I said, and I'm just, again, focused on quality of life, but she looked great. So I probably did what a normal physician would do. I was stalling. I brought her back a couple extra times and really said, can we talk about your goals of care? Are you sure you want to do this? And she said, you're not listening. I want to do this. And so I referred her to one of my radiation colleagues, and he saw her and called me back and said, I think I can get her through the radiation. And I was just shaking my head. I was like, shoot, because now that you can get her through the radiation, I now have to design something to pair it up with a chemotherapy arm. And lo and behold, she did 7 weeks of the treatment together, and she had 0 side effects. Her cancer went into remission. She lived another 4.5 years cancer-free. And I remember her coming into the clinic and just pointing her finger at me and says, I told you so. I told you I could do it. So that was really eye-opening. The mind and spirituality is very, very powerful. A lot of times we're addressing a lot of the physical symptoms, but the emotional and the psychosocial aspect and the support and the spiritual health is so important. It all works together. I have some people that are very weak, but their mind is very, very strong. If they decided they're going to do something, they're going to do it. And I'm sure you guys all have friends and family members too who the sky could be blue and they'd be, how come it's so blue? And so it's just a way of looking at things. I tend to be a more positive person and try to encourage our patients to do the same thing. The glass is always half full, not half empty. And if you tell yourself it's a good day and you're going to wake up fighting and you're going to get through it, I always tell my patients, keep your eye on the prize. all the side effects. I can list the 5 million side effects, but if I told you that you got to get through that door so you can cross that bridge to get to the other side, it doesn't matter how many ditches or how many gorges we have to cross. We just got to get there. And once that patient has made up that decision, you can't stop them. The initial point of hearing you got the diagnosis of cancer, there's different phases. I'm sure some of you guys experienced it. You may have other family members have known about it. It's a sense of denial at first. Why me? And then there's this negotiation phase. Some of us talk to God, some of us talk to other higher powers and say, why me? And then it gets that last point of anger. But once you cross that last fourth step and get to the fifth step, which is acceptance, where you know, okay, this is something I got. I now realize it's my disease. What do I got to do? And as soon as I can get those patients into that last phase of, okay, I'm here now. What do I got to do? And that makes our job and the nurses, the medical team, and the behavioral team just that much easier. So that's kind of a little bit about cancer and the diagnosis part. I really want to talk about survivorship and wellness. So most of people will define the survivorship into two parts. Most of us are focused on, okay, well, once we finish the treatments, our cancer is in remission. How does life look after? How does it look like after that? We oftentimes forget to talk about during the treatment what does survivorship mean. And it means different things. I'll focus mostly on the end, but I'll talk a little bit about survivorship during the treatments. It's difficult to have that conversation with a loved one when somebody's on treatment. I see many children saying, Mom, Dad, keep going, keep going, keep going, keep going. But I also have to sometimes pull them to the side and say, look, I know you want them to keep going. I want them to keep going. But at the end of the day, the patients are the one going through the treatments. And sometimes it's very difficult, and it's very difficult for the patients to really tell their daughter, husband, son, how they're truly feeling. I find it very helpful sometimes when I bring my patients in, I just do a little one-on-one, and all of a sudden, all the emotions come out, all the scary questions that need to be answered are just poured out on me, and I'm glad to be a soundboard because I know it's very difficult to engage in that conversation. No one wants to be the one to say, hey, mom or dad or husband, wife, have you thought about stopping? No one wants to feel like they're not in their corner. And so I always encourage you guys to just have that really honest discussion. I'm always hoping for the best, but our job is to try to prepare you for the worst as well. And so if there's other people you can rely on, and friends and family members who are nurses or pastors, we have some psychiatrists, please always seek help and see if there's a way that you can have an honest conversation. Moving on to, once we finish the treatments, what does that look like? I have a lot of patients who get used to the plan, get the labs in time every week. We see the nurses every 2 weeks. We see the doctor every 3 weeks. And you kind of get in this rhythm, and there's a plan. And as soon as we finish, all of a sudden it's like, wait, you're going to see me in 3 months, 6 months? The cord almost gets separated. So there's almost a little anxiety there, and that's where words of encouragement come from us and say, hey, look, you're going to be okay. We're not going to let you go. We're going to continue to monitor you. Typically, that's a scan or a lab every 3 months. And we go for 3 to 5 years, typically. I get asked often, Doc, am I cancer-free? And don't be hesitant to ask that question. Am I cancer-free? What does it mean when you say partial remission versus complete remission? When am I cured? And those are very difficult questions to answer definitively, but typically we like to go monitor people for the first 3 years. And after 5 years, if you're still cancer-free, a lot of us will still be a little hesitant, but say, hey, you're potentially cured. Unfortunately, cancer can do whatever it wants to do. I've had patients, unfortunately, about 25 years out where the same cancer came back and just stayed dormant the whole time. And so in my practice, I never like to discharge people completely, even if we hit that 3, 4, or 5-year mark. I like to keep people close, and they feel a little bit comfortable as well and say, I'm glad you're looking at me, and keeping an eye. And then we keep an open door. If you develop any new symptoms, loss of weight, something just doesn't seem right, my staff knows, bring the patient in. I don't care what the question is, just bring them in, and let's do some tests. So again, once we have finished the treatments, those are the typical follow-ups, follow-up every few months. But what can I do? I get asked this question. What can I do to minimize my chances of the cancer coming back? For some of the breast cancer patients, it's really staying on some of these anti-hormonal drugs, which we've now given for 5 or 10 years after chemotherapy, that can keep the cancer at bay. We also know that avoiding things such as hormone replacement drugs, birth control pills, these things can drive cancer risk, especially in our female patients with ovarian, uterine, potentially breast cancer, so we like to avoid those things. For other patients who have had stomach or colorectal cancers, we talk about avoiding nitrites, which are basically smoked barbecue. I mean, everyone's like, I love barbecue. I love occasional pickles or kimchi beef or the Korean food. And we think that some of these preservatives, especially on the pickled substances, can cause like stomach cancer. So we avoid these things. In colon cancer patients, we have patients who eat a lot of red meat. So we think on the Western diet that the Western diet affects men and women and increase the incidence of colon cancer. And so it's very important to try to limit the red meat consumption. We know this because we've taken samples of patients who came and immigrated, specifically from Asia, who had mostly a beefless type of protein diet, a lot of seafood, and you bring them over, and within 30 years of one generation, the cancer incidence goes up as a Western diet. So we know that diet has some implication for cancer. For colon cancers, we try to recommend taking folic acid and aspirin. And the whole premise of taking aspirin, for example, is another prevention strategy to try to prevent polyps from forming. So I'm not sure how many of you guys have had colonoscopies in your life, but the reason why we do these colonoscopies routinely is to look for these polyps. They're finger-like projections. So not all polyps turn into cancer, but all colon cancer comes from a polyp. And so we can do these colonoscopy procedures routinely, find those polyps, remove those polyps. You're technically preventing the cancer from coming back. Aspirin also has a similar property in that it prevents these polyps from forming. And so if you can't form these polyps, then theoretically, again, you're decreasing your risk for developing things like colon cancer. So we addressed breast, we talk about stomach, we talk about colon. For females, for pap smears, I mean, just doing the routine checkup, that's very, very important. Pap smear every year, and that will prevent cervical cancer and early uterine cancer. And for men, this is a debate whether we should continue to do digital rectal exams and check your PSA level, but I still believe in it. My own father had prostate cancer, and the reason why we found out about it is because I had him check his PSA. So we have different societies arguing, saying it's not useful, but had I not had my dad checked, we wouldn't have found out about the cancer. We wouldn't have been able to eliminate it. So I'm a proponent of being aggressive and try to continue doing these screening tests to try to, again, minimize the risk of the cancer being a late stage. With regards to survivorship, once you finish, I mean, your whole life changes. What do I find important now? I try to encourage my patients to find some activity that they enjoy doing, because now that you've made it through, you may have had to give up your job. So the question is, do I go back to work? Even interpersonal relationships with your spouse may have changed. With your children may have changed. Finances, It's a very difficult topic to talk about, but I think they have reported 1 in 4, potentially 1 in 4 individuals become financially bankrupt because of all the expensive treatment costs and the inability to go back, to work during that time. So seeking financial counseling through a social worker, or again, talking to some of the financial planning team while you're getting the treatments to see if you qualify for copay assistance, foundation assistance. These are all very important topics. What do you do about stress reduction? Once you've survived, it's always in the back of your mind. Is my cancer going to come back? And it's never going to go away. That anxiety is always still going to be there. But is there something that you can do to help minimize that? And sometimes it's just participating in workshops and seminars, just like one today. Presbyterian has a great breast cancer meeting, the survivor meeting, and they discuss this every single month and meet up with questions. I used to volunteer at other churches to have these open forums to do questions and answers. American Society, there's one in every city. It's very helpful if you guys band together and help one another, because there are more patients with cancer or have fought and beaten cancer than there are healthy people, believe it or not. You just may not know that the person next to you is actually affected. And sometimes not only does it help you as an individual to share your ideas with everybody else, but think about the next person who's just been diagnosed, and to be able to share your experience and help alleviate some of the stress and encourage that next person to get through. Well, now you're giving back. I had a patient 15 years ago, I don't even know if he's here, but he was getting his treatments and he made it his mission during his treatments. He realized he was very cold. He made his mission to give back, and he's been making blankets. I don't even know if you guys have participated in that, but he goes through all the cancer centers and just donates blankets for all the patients, so that they're warm during their treatments, because sometimes our treatments, the fluids are a little bit cold. And so these are little things that he's decided to now make it his mission, that next step in life, to give back. And you can do that as well. If you guys are ever looking for more information specifically on survivorship, American Cancer Society has some great information on their websites. Mayo Clinic also has a website called Mayo Cancer Connect. And there's seminars and videos that you guys can watch on YouTube. They're for free. Papers you can download and just say, oh, this is the plan. I'm going to avoid this, I'm going to avoid this, I'm going to avoid this. They talk about dietary changes, eating healthy. I don't have to lecture or tell you guys to eat the 4 basic food groups from elementary school. It's very important. Bread, cereals, fresh meats, fruits and vegetables, things that have lower carbs and weight loss. All of these prevention strategies help prevent cancer from coming back. We didn't talk about smoking cessation or alcohol. If we eliminated alcohol and tobacco in the world, I would say there'd probably be 75% less cancer today. So most people think of smoking just affecting the lungs, but smoking can cause head and neck cancer, bladder cancer, kidney cancer. They even have linked it to cervical cancer. You take alcohol, for example, it's not just having liver cirrhosis and developing liver cancer, but throat cancer, again, esophageal cancer, stomach cancer. So just eliminating things that you can eliminate, these are great. Obviously, you can't change your genetics, so we can't do anything about that, but eating healthier, cutting out alcohol and smoking, exercising. So exercising, losing weight, avoiding, again, some of those foods that I just mentioned that are high in nitrates and smoke things. And then making sure you just follow up with your doctor and your medical team, just making sure they do the routine tests, getting checked up, and having other friends and family members checked up. Typically, one example, when we diagnose somebody who has a cancer diagnosis, there's probably about 5 to 10% of them who actually have a genetic mutation. Once we diagnose them to have a positive mutation, we bring their entire family. Bring your brother, bring your sister. I test them. If they're positive, then we have to test the children as well. So it's not just focusing on you. When we see you as an individual, we see the whole entire spectrum. Who else could be involved? And get everybody involved. I don't know if I got any other topics or anecdotes to talk to you guys about. I'm probably quick on time. I didn't really want to make this a Q&A. I know we have the next section to do the question and answer. But does anybody have a burning question that they want to ask while I'm up here? And again, I find it very common that everyone shares very similar things. Yes?
My family has been told a number of biomarkers. One is the
Lee-Fraumeni syndrome, yes. Mm-hmm.
What is that saying that you're destined to get it?
Lee-Fraumeni syndrome is just one of many genetic diseases where you're lacking a protein called a tumor suppressor gene. So in all of us, we all have cancer simultaneously right now. And you're like, wait, did I hear you right? We all have cancer? Yes. But we have an inherent immune system in our body that acts like a radar system that basically is destroying that cancer. It's also protecting us from infection and viruses. But in patients with what you just mentioned, with the Lee-Fraumeni syndrome, that gene, that tumor suppressor gene that keeps that radar system active and on, is down. And so patients with that immune system depressed can now have these cancers, and various cancers, not even just one, can grow at multiple times. I've had patients where I've unfortunately diagnosed 3 separate cancers at the same time on the same hospital admission. 3 different cancers, not one cancer that moves somewhere, but 3 different cancers because of the immune suppression similar to the syndrome you just mentioned. And so it's very, very important, if you know you got a family history of cancer, please mention that to your physician so that he or she can kind of take down a pedigree and try to analyze and see if there's a relationship between multiple generations and age. I've had friends with breast cancer at the age of 20. It's not normal to have breast cancer at the age of 20. We already know that there's some mutation that is going on. I had a 27-year-old with stage 4 lung cancer, never smoked. So these are flags. You don't need to, be a doctor. No, wait a second. You don't smoke, and you're 27, and you already have stage 4 cancer. Why? And over the last 10 years, we've identified these biomarkers, to your point of what you just said. There are now at least 10 biomarkers for the lung that are seen in non-smokers. Originally studied in Japan because they were analyzing these women from Japan and questioning, why do you guys all have lung cancer? None of you guys smoke, and no one in your family smoked. And they identified, I like to describe it like a switch, like a light switch. And that light switch mutation got turned on. And so just identifying the right drug to turn that light switch off in these specific patients, men and women with these targeted biomarkers for their lung cancer, their overall survival increases probably like 300% compared to someone with the exact same stage but doesn't have that driver mutation or that light switch that we can turn off. So that's why we typically, going back to the first part of the discussion, like to get all the information, check the pedigree, check the biopsies, check all the scans, because I don't want to be asked, Doc, what's my prognosis? And think, hey, we're talking about a year when you've got one of these mutations. My last 2 patients went 13 years on it with stage 4 lung cancer, which would never have been heard of even back when I was in training 20 years ago. Yeah, all of this stuff is new. It's a great question. Yeah, there's all these, again, biomarkers, and you'll hear these big buzzwords: next generation sequencing, precision medicine. So don't be afraid to ask your doctor, do I have one of these mutations? Do I have one of these actionable targets that I might be able to take instead of the traditional chemo that might prolong my life? Yeah, great question.